Good evening, everyone. Welcome to our next few sessions. I'm saying this because we are going to have multiple sessions today in short, so that you can watch it at your convenient time. And the topic that we're going to discuss today is tuberculosis, one of the most frequently encountered disease, both clinically and on your question papers. Um, so in the first part, we are going to discuss about the pathology, and the second part, we are going to discuss about the clinical features. And in future, in additional parts, we will discuss the rest of the topics in tuberculosis. So we will straight away move into the topic. Today, the topic is part one, pathology of tuberculosis. In this, all your queries that you have about the Gons foci complex and how the tuberculosis infection happens, what happens after the infection happens, what are the possible outcomes, all those things will get answered in this short video. Okay, stay tuned. And I would start sharing the screen now. Okay, so let's start from the first slide. Okay, so tuberculosis pathology. So in this slide, you will get to see the host, the agent mycobacterium, and what happens to the lung. Okay, and this slide is just to get familiar. What are all the structures that are in play in this infection tuberculosis? Okay, so and with time we'll just go through all these things. Okay, so in patient when he is having active tuberculosis, he will have chronic cough. And one of the guideline that is there for us to know is if the patient has to chronic cough which lasts for more than 2 weeks, you need to suspect tuberculosis. Well, the current COVID has changed a lot, but still the old adage through which we were diagnosing tuberculosis were to start suspecting tuberculosis if the patient had more than 2 weeks cough. Okay, and need not be blood or just the duration of more than 2 weeks. Okay, and this is how the infected lung would look like. You see, like the pathology shown there, and this is the mycobacterium. This is a acid fast bacilli. You can see that with the red color, usually the Ziels Nielsen staining. Okay, so we will go into the actual pathology. So let's see like what happens. So consider this is a example for primary tuberculosis. So the primary tuberculosis is when the agent, the mycobacterium tuberculosis, comes into contact with the host, that is the human. So for the sake of explanation, take this picture, no bias to gender, please, but just for the sake of examination here, for the sake of explanation here, consider this male silhouette is a host and this female silhouette is a agent, which is the mycobacterium tuberculosis. And what happens in the first encounter? So there is a fight between the agent and the host. Okay, and that will be the primary tuberculosis. 95% of the primary tuberculosis may not result in any symptoms, right? The host gets infected and the bacteria lodges in, but the patient may not show any symptoms. The rest five, there can be like the body may be defeated at its first time contact, and that condition will give rise to primary progressive tuberculosis. Okay, so what we now know is primary tuberculosis and primary progressive tuberculosis. Okay, so let's see what happens in the rest of the 95%. So the next phase that will be called as latent tuberculosis. Here there is no apparent fight. So patient has no symptoms and bacilli or the lesion that is happening due to bacilli doesn't seem to show any more activity. But actually there is some activity. For example, if you look at this, now there is no apparent fight happening, there is silence there, but there is still some dynamic activity happening. Now the agent must be thinking something about the host, and the host must be, there is a constant activity that is there, may not be apparent, but that is happening in between this agent and host. Okay, and that is something called as latent tuberculosis. Though literatures now mention that instead of latent, we can replace the term with persistent tuberculosis. Okay, so we are slowly building the phases: primary tuberculosis, primary progressive tuberculosis, or the latent tuberculosis. So let's see what is the secondary tuberculosis or post primary tuberculosis. Okay, please note, post primary tuberculosis is different from primary progressive tuberculosis, where there was no gap, no latent phase in between. In secondary or post primary tuberculosis, there is a pause, like a latency or a persistent tuberculosis with no apparent activity between primary and secondary tuberculosis, also called as post-primary tuberculosis. So what happens here? The host succumbs to the pressure by the agent. Okay. So what happens now is the tuberculosis now gets a dominant hand over the host and starts showing his symptoms. So now we understood the phases. I'm just recalling the phases again. Primary tuberculosis, which 95% may just stop there and may not show any more symptoms, or the rest 5% may go into a phase called primary progressive tuberculosis, where the host continues to deteriorate. Or in the 95% of the patients, they can enter a latent phase where there is some activity happening, dynamicity is still maintained between the agent and host, but apparently you can't see any symptoms or any other features, any other worsening. And then later, when the host becomes weak due to any causes, that time when the mycobacterium tuberculosis gains the dominant hand, that time the patient can manifest secondary or post-primary tuberculosis. Okay, so now let's see what is the lesion. How will the lung manifest this, the multiple contacts and the infection and all that? So first thing that you need to be aware is something called as Ghon's focus. So here, usually this is the first area of the lung that gets involved with primary infection. So the agent enters to the lung and reaches the subpleural surface, mostly in the middle of the lung. Okay, so this subpleural area in the middle of the lung is called as Ghon's focus. This is where the bacteria lodges and starts multiplying. It is said that even a single bacilli is sufficient to cause this focus. So then what happens? So this Ghon focus becomes Ghon's complex when there is a lymphatogenous spread from this area to the paratracheal or mediastinal lymph nodes. Okay, and put together, the Ghon's focus plus a mediastinal lymph node or a paratracheal lymph node is called as Ghon's complex. Okay, now uh, what happens next? There are multiple things that can happen after this. So if these lesions gets, the body contains the infection at this stage and these areas get fibrosed and calcified, they are called as Ranke's complex. Okay, so you see the difference between Ghon's complex and the Ranke's complex is just that whether the lesions are active or fibrosed. And then it is possible that the infection was not contained. Then what happens is from the media, like the lymph nodes that are here, from here, hematogenous dissemination of the infection can happen. And usually that happens to the apex of the lung with good aeration because tuberculosis bacterium loves good oxygen tension for their growth. Okay, that is one of the reason why apex of the lungs are involved. Okay, so now you see there is hematogenous spread which is shown on this in this picture to the apex of the lung. However, if the infection is contained at this stage, then the apical lesion is called as Simon's focus. Okay, it's again a fibrosed lesion. The apex part of it, the apical lesion which is fibrosed, is called as Simon's focus. However, if the lesion that was that developed in the apical area of the lung remains active, that is called as Asman's focus. I just want you to get familiar with these terms, which can show up and which will show nicely when you write these things on your paper. Okay, that's why I'm repeating the names. So this Aspen focus is an active lesion, and the Simon's focus is a fibrosed lesion in the apical area. Okay, so just recalling those complexes. So this and focus. This is the Ghon's focus, subpleural area in the middle of the lung. Ghon's complex, Ghon's focus plus a paratracheal or a mediastinal lymph node. Ranke's complex. A fibrosed Ghon's complex becomes a Ranke's complex. Hematoid spread to the apex. So in the apical lesion, there are two names that are there to remember. A fibrous lesion is called as Simon's focus. A active lesion is called as Asman's focus. Okay, and now let's see, like the hematoid dissemination need not stop only in the apexes. If in a weakened host, it can spread elsewhere, like the both the lungs. Okay, so in this case, what happens? It is possible like some lesions get healed and the patient may not show symptoms, or all lesions can get rather than saying healed, I would say like all the lesions were contained with few bacilli surviving intracellularly, and there is a phase where the bacteria can reactivate. So the body and the bacilli, when they are fighting together, if the body claimed the upper hand, that time there is, containment of lesion. But again, due to some reason, if the body weakens, then there is reactivation. And this reactivation again is predominantly seen in the apical regions where there is good oxygen tension, good aeration of the lung. Okay, and commonly, if you want to understand the in the lung, it's the basal areas which are very good perfusion happens, like blood enters well compared to the upper part of the lung. In the same way, the air that enters the lung comparatively is like ventilation is better in the upper part of the lung when compared to the relatively lower areas of the lung. Okay, so this ventilation perfusion is not uniform in the lung. That's the reason why you have more aeration in the upper part of the lung, and that becomes a foci for reactivation. Pardon the spelling, it's PION. Okay, and then there is cavitation. So the next we will discuss also like what happens when the bacilli grow. The normal reaction that happens is the body starts accumulating the immune cells, lymphocytes, and giant cells, macrophages, and these cells transform into epithelial cells and giant cells with intracellular bacilli, forming granulomas. With time, the central part of the granuloma can show necrosis called caseous necrosis. Okay, due to there is no good maintenance of the tissue in between in the infected tissue, and that shows cheesy necrosis because of the enzymes that are released, causing proteolytic digestion of the center part of the granuloma, resulting in cavities. Okay, and it is not necessary that it's only the upper part. As I told you previously, the whole of the part of the lung can be involved. Okay, so the hematogenously, and this is also like an example showing just to show a slide which shows that any part of the lung can be involved and the whole of the lungs, both lungs included, can be damaged. Okay, and also a point on heterogeneous seeding. Though we discussed in this video about heterogeneous spread to the apex, it is not limited. The heterogeneous seeding of the bacilli can happen to various other organs outside the lungs also. That is what this slide is meant to explain. Okay, and this is a revision slide. I am going to go one by one, follow what I am speaking now. So first thing is tuberculosis, and pneumonitis tuberculosis, easy to remember fairly. So T for tiny droplets. So the droplets are in the size of less than 5 to 10 micrometer in diameter for transmission. So these bacilli are dispersed in the air, and people who are in close contacts can inhale these bacilli, resulting in primary tuberculosis. Next is uncommon routes exist. Yeah, apart from the just the breathing these droplets, there are other ways this bacilli can enter. Example through the skin or the placenta, especially in the healthcare workers or caregivers of tuberculosis patients who have lesions on the skin. Okay, and then what happens? There is a fight between bacilli and the body, which we just discussed, and that can result in primary tuberculosis, primary progressive tuberculosis, latent tuberculosis, or persistent tuberculosis, secondary or post-primary tuberculosis. These are the outcomes that can happen due to continuous fight between the bacilli versus body. Next is extrapulmonary seeding. Again, that we discussed. Apart from the lung, after this infection, like this fight, if the bacilli takes a dominant hand, it will start extrapulmonary seeding. Something called as miliary lesions happen at this stage where hematogeneously the bacilli spread and they start forming 1 to 2 millimeter millet-like lesions all over the body, including lungs, like starting with lung, including the liver, spleen, etc., where they will cause this seeding called as milia. Okay. Next, R for reinfection or reactivation. So this is difficult to tell whether the patient who had old tuberculosis, for example, in adolescent, and he's presenting to you again with tuberculosis at the age of 30, whether it is because of reinfection or reactivation. But in either case, again, the area that is usually involved is the apex of the lungs. Okay, and next is C. So C for cell mediated immunity. So normally when there is a body response, we usually determine either it is a humoral mediated response or cell mediated response. So here in tuberculosis, it is the cell mediated immunity that takes more part. And then we discussed like how the cavities are formed, because there are like granulomas that happen with cell mediated immunity, and there is central caseous necrosis of this tissue of this granuloma, resulting in cavity formations. So cell mediated immunity, cavitated lesions, central caseous necrosis, calcification, all those things are in C. Next is U for umbrella of manifestations that include Gons focus, Gons complex, Rankis complex, Simon foci, tuberculoma, and miliary lesions. These are the things that we currently discussed. And you can remember that under the term umbrella of manifestations. Next is lymphadenitis. Well, apart from the lung, we just saw like even in Ghon's complex, there is lymphogenous spread resulting in involvement of mediastinal or paratracheal lymph node. So even if the lungs are not involved, then the most common system that is affected is the lymphatic system in the form of lymphadenitis. So the extrapulmonary direct tuberculosis, the most common would be lymphadenitis, okay, especially the cervical areas. And O for occult cold abscesses. So this heterogeneous seeding or sometimes without apparent primary lung lesion, you may find abscesses characteristic to tuberculosis. For example, in the cervical region or something also called as psoas abscess. One more characteristic feature about these abscesses are when compared to other bacteria is they result in something called as cold abscesses. So what does this term cold imply? So it means the normal signs of inflammation, which is calor, dolor, tumor, rubor, loss of function. These things are not seen in abscess, which is formed by tuberculous bacilli. That's why the term cold abscess. And the spinal tuberculosis can result in another named lesion called Pott's disease, and I for immune deficiency or immune reconstitution inflammatory syndrome. So the patients with tuberculosis, like who are prone to have infection or present with worsening aggressive lesions, are patients who have immune deficiency. That is HIV, virus infection, and diabetes mellitus. One thing about these two is diabetes mellitus and HIV. Though we have too much of stigma attached to HIV, diabetes also is a equal risk factor in terms of the risk of tuberculosis. So, patient with HIV and patient with diabetes both are at equal risk of acquiring tuberculosis infection and manifesting the symptoms. So both of them are at the equal spectrum in clinically. Um, and immune reconstitution inflammatory syndrome, as the name implies, this is quite little opposite. So, patient who has already been infected due to weakened immune system, especially in HIV patients, when with treatment they start gaining immune reconstitution happens, then there is an inflammatory response. Okay, so here there is worsening of lesions and infiltrate, lung infiltrate, and all when there is immunity improvement. Okay, so when you are resensitizing the body to the bacilli, like with building up the immunity, there is more aggressive forms of lesion that happens. So as the name implies, again, immune reconstitution inflammatory syndrome, the exaggerated response of inflammation causes harm to the host. So this I gives two: one is immune deficiency and immune reconstitution. Both the things are there in the letter I. The last one is skin tuberculosis. Well, again, skin tuberculosis will need a separate discussion. We will not be having that in today's session. So that is the thing with the skin tuberculosis. So with this mnemonic, I wish that you will now be able to remember most of the part of the pathology and the clarity regarding the different complexes that we usually hear with relationship to tuberculosis. Okay, so few pictures to end this part of the presentation. So this is Ghon's focus of active tuberculosis. So you see a central lesion here, and then the venous spread, which is the lymphatic origin. This will be an example for Ghon's complex. And this is an example for a cheesy material that is there inside the lung tissue, showing caseous necrosis. And tubercular lymphadenitis with sinus. So you see here must be a long-standing tubercular lymphadenitis, and with sinus now. So characteristically, you can note there are no severe signs of inflammation associated with the sinus and the discharge. Well, that brings us to the end of part one of tuberculosis pathology. I wish you enjoyed it. Meet you soon with part two. Take care. Bye. I'm going to stop sharing the screen now. So yeah, part one just be now completed. Part two I will immediately load in a few minutes. Well, also if you are a medical student, I have some good news to you, especially if you are the last year final student. So in many parts of India, there are exams now coming up for the final year students, and I am trying to do some activity to support some of the students. So what I have started is a mentorship program for a 2 month period. For more details about this, you can visit the website www.drdeepthinker.com. I'm typing the website here. Okay, so this is the website in which you can enter and find more details about the mentorship program. Okay, and this will be a 2 month mentorship program where I will be supporting you in scheduling the your topics and preparation, and I'm going to be there with you, walking you through this exam as a mentor. Okay, and my intention is that you and your family, in this phase of exams, the usual way of being that happens in home, uh, the tense environment that can set in, well, we are going to deal with all that powerfully. That's the intention of this session that we're going to, the mentorship program that we're going to have. Okay. So yeah, so hope to see you there. If you haven't registered, or if you are a medical student who knows other students who are in final year who may be interested, please let them know about this mentorship program. And I'm going to have not more than 50 students because I need to serve each of them individually. Okay. Yeah. See you with part two soon. Bye.